start?
Yeah, you can start in 3, 2, 1. Please go ahead.
Good evening, ladies and gentlemen. Welcome to yet another live webinar on immune-mediated TTP, novel approaches to the diagnosis and treatment and follow-up, which is brought to you by Mumbai Hematology Group and ably supported by INTAS. This series of webinars, which is the longest running series since the pandemic across the world, has been brought to us by none other Dr. Professor M.B. Agarwal sir. Sir is an institution in himself and inspiration for many and teacher of teachers. So we are grateful that you are coordinating and planning the series every weekend, Saturdays and Sundays, and all the doctors, not only in India but across the world, are benefited out of the learnings from experts across the world. So, thank you, sir. And so, over to you for the proceedings.
Can you see my screen?
Yes, sir.
Okay. So, good evening to one and all. Today, our guest speaker is Dr. Spiro Catalan from Ohio, US. He will be lecturing on immune-mediated TTP, novel approaches to the diagnosis, treatment, and follow-up. This webinar is brought to you by Mumbai Hematology Group, supported by INTAS and managed by Perfect Square. I thank Dr. Manoj Kumar and his team from INTAS, Mr. Yash and Kalpesh and the team from Perfect Square, Executive Committee of Mumbai Hematology Group, our guest speaker, Dr. Spiro Catalan, our discussants who are themselves eminent hematologists, you participants for sparing your Saturday evening, if you are from Mumbai, India, and morning or afternoon, if you are from the rest of the world. Tomorrow morning at IST 11:30 a.m., we have Dr. Maria Metius from Spain speaking to us on multiple myeloma and ASH update. Our discussants today include many important personalities. The names are put up alphabetically over here. I'll just briefly introduce them to you. We have Amit Jain from Mumbai, Aniket Moite from Pune, Professor Chandrakala from Mumbai, Girish Balikai from Dharwad, Hamza Yusuf Dalal from Mumbai, Group Captain Dr. Harshit Khurana from Pune, Nishad Dhakate from Nagpur, Riya Balika from Nagpur, Samir Manikari from Pune, Sweta Lankat from Pune, Dr. Varun Bafna from Kolhapur, and Dr. Vidisha Mahajan from Mumbai. Now it's time to introduce our guest speaker for the day. Dr. Spiro Catalan is Professor of Internal Medicine in the Division of Hematology at the Wexner Medical Center at the Ohio State University. He is also the director of the Benign Hematology Program at Ohio State University. He received his medical degree from Ohio State University College of Medicine, completed his residency at Ohio State University Hospital, and after this, he went on to complete fellowship training in hematology oncology at the University of Chicago Medical Center. After completing his training in hematology, he returned to Ohio State University, where he presently remains on the faculty. His clinical and research interests include thrombotic thrombocytopenic purpura and atypical hemolytic uremic syndrome, with an emphasis on immune-mediated TTP. He directs the Biomarker Reference Lab at Ohio State University, which performs correlative lab studies for ongoing research. He has a long-standing interest in the development of long-term complications in patients with a prior history of TTP and the mechanisms for their development. And we heard this talk during ASH a year ago. He also has worked to establish the United States Thrombotic Microangiopathy Clinical Consortium an organization of over 15 academic medical centers that was organized to conduct collaborative research in both thrombotic thrombocytopenic purpura and atypical hemolytic uremic syndrome. Today, he will be lecturing on immune TTP, novel approaches to the diagnosis, treatment, and follow-up. So, sir, we hand over to you.
Thank you very much. Let me get my screen pulled up. Let's not start in the middle of the talk. Very good. Can you all see my slides okay?
Yes.
All right, good. Well, thank you, Professor Agarwal. Really a pleasure and an honor to be invited to speak in this webinar, and this webinar that's really inspired by you, Professor Agarwal. So this is really meant to be an informal session, so feel free to raise questions anytime they come up, or we can talk and ask questions at the end. But I think what we're going to talk about is highlighting sort of the evolution of TTP from a fatal, uniformly fatal disease to one that is now very treatable and able to put it into remission, but also one where there is an evolving sort of approach to the follow-up of these patients. What's being, I think, become increasingly important is not necessarily the acute treatment, but the long-term follow-up that's going to have an impact on these patients. These are my research disclosures. I've done consulting work and collaborations with Sanofi Genzyme, Alexion, as well as Takeda. So it's important to start out with, in my institution, the term thrombotic microangiopathy, which obviously is a pathologic as well as a clinical term, many times is viewed as a diagnosis. I get a phone call that says, we've got a TMA. And I tell them, well, you've got a good start. We need to work on what that TMA is. And what we're going to talk about today is immune-mediated TTP. But there are multiple other things, rare, like AHUS, atypical HUS, DIC, but also malignancies, metastatic malignancies, autoimmune disease with vasculitis, pregnancy-associated TMAs, infection, sepsis, hypertension, a lot more common things that can cause a TMA. So when you get a diagnosis of a TMA, it's not a diagnosis, it's a starting point to understand that you need to find out the cause of that patient's TMA presentation. As you've already heard, we're going to focus on immune-mediated TTP, which is the consensus term from the International Working Group. It's also called acquired TTP. But I think many of you already know, in the normal state, under situations of high shear forces in the microvasculature, it's this ADAM-TS13 protease that cleaves these ultra-large multimers that are secreted from endothelial cells into the physiologic size multimers to mediate thrombosis where we want it to occur. In the situation where we have an acquired deficiency of the protease, an antibody-mediated blocking of function or clearance, or a congenital absence of that protease, you don't get cleavage, and you get the spontaneous formation of microthrombi throughout the body in the microvasculature, again, in the small arterioles where the high shear forces exist. So the ADAM-TS13 protease, and this is really its only known function to date, it is central to the pathophysiology of TTP. But it's also not everything, and I think you're going to see that, I hope, by the end of the talk. In animal models, when mice were bred to be ADAM-TS deficient for study of the disease, they did not spontaneously develop TMA findings. They didn't develop a thrombocytopenia, the anemia, the fragmented cells. It took additional measures, so that what we would call clinically as a second hit. But in the lab, it was Shiga toxin was injected, collagen epinephrine, to trigger a susceptible mouse to develop a TMA, really leading to the second hit hypothesis. And I think you see this quite well in congenital TTP. And this is some work from the French TMA group led by a good friend of mine, Paul Capo. And I think it's very informative to look at what they saw was 42 patients with their first episode. These are females with their first episode of TTP that occurred while they were pregnant. So 19 of these patients, they did not have an inhibitor based on either inhibitor titer testing or an ELISA. In remission, 9 of these patients recovered the ADAM-TS13 activity with immune suppressive therapy, suggesting it was a lab testing issue more so than anything else. But 10 of these patients were confirmed to have congenital TTP, which is much greater than you would expect in the general population or in patients presenting with their first episode of TTP. So if you will, this is really the human model for the development of TTP. These are 10 women who had a congenital deficiency of the protease throughout their lives, but it took getting pregnant to lead to that second hit to develop an overt TTP episode. We're going to talk about this plasmic score, which really is an aid in diagnosing TTP. It's a good model to predict the likelihood of severely deficient ADAM-TS13 activity. But really, to simplify that, you can go back to work done by us as well as many of my other colleagues over the years to look at the clinical differences in patients who had severely deficient ADAM-TS13 activity and those that didn't. And I would point out to you there were different thresholds used. The most common one today is going to be 10%, but these are really divergent populations. So whether you use 5, 10, or 15%, you're not missing very many patients. These are pretty spread. But if you look at the severely deficient patients, what you see is they tend to show up, these are at presentation prior to treatment. They showed up with a lower platelet count and renal injury, but not renal failure. Patients who eventually were found not to have severely deficient ADAM-TS13 activity. And this may be a population enriched for a complement-mediated TMA or atypical HUS, or a hypertension-induced or a drug-induced or a HELP syndrome. But these non-ADAM-TS deficient TMAs had higher platelet counts, as you can see, and greater degrees of renal injury and a greater likelihood to have renal failure. If you look at the plasma score, it really is just based on that principle alone. And they used a platelet count of 30,000, a serum creatinine of less than 2.0. So you can see in the scoring system, you have an intermediate or high risk for the presence of a severely deficient ADAM-TS13 activity. And those are actually the patients who you need to do empiric plasma exchange until you get confirmation with the ADAM-TS13 activity. But to get to 5 is really not so difficult. The diagnosis of TTP is really a clinical diagnosis. It's thrombocytopenia, fragmented cells, with the absence of another explanation. So if you have a platelet count less than 30,000, renal injury but not failure, and evidence of hemolysis, right away you're at 3 points in this plasmic score. The clinical evaluation is kind of consolidated down into these variables, where no active cancer, history of a solid organ transplant or stem cell transplant, and an INR and MCV. The MCV is not clear why it points out these differences, but patients with TTP tend not to be coagulopathic. So you can see very quickly with a low platelet count that's less than 30,000, creatinine that's less than 2.0, and no other clinical explanation, you're going to be in the intermediate or high probability of having an ADAM-TS13 deficiency present. Again, this is not a replacement for the testing, but a guide until you can get that testing back. A common question I always get also is, can I still use the ADAM-TS13 activity if it was obtained after the start of plasma exchange therapy? And we did a quick study several years ago now looking at 19 patients who were undetectable and rechecking the ADAM-TS13 activity prior to each day's plasma exchange procedure. So here you can see after 3 plasma exchange procedures and immediately before the 4th, and I have to emphasize that this is not ADAM-TS testing done right after plasma exchange. It's done immediately before the next day's planned procedure. Even after 3 plasma exchange procedures, you still have 80% of patients who had undetectable activity. So only 20% that actually corrected it. So in general, if you miss this and get a plasma exchange after the first day's plasma exchange, it's likely still going to give you valid results. So what are the goals of treating, treating TTP? We obviously want to induce a clinical response of the disease, and we use plasma exchange, as you can see the figure here on the right. as well as immune suppressive therapy to normalize the platelet count, which we use as a surrogate marker for stopping new microvascular injury, new microthrombotic disease. And we obviously want improvement in short and long-term organ function. How plasma exchange works, I think, is still a bit of a mystery, whether it's predominantly the removal of an inhibitor or whether it's adding back functional protease is not absolutely clear. But one thing that we're going to talk about here in more detail is this exacerbation, and it's defined as the need to restart plasma exchange in the first 30 days after the last plasma exchange procedure. And it's not just a study endpoint. It's really an important clinical endpoint for patients. With the advent of caplacizumab, an A1 domain blocking therapy or anti-VEGF therapy, as well as what's coming with recombinant ADAMTS13, even for acute immune-mediated TTP, the definition had to be changed. It's now recurrent thrombocytopenia or the need to restart plasma exchange therapy more than 30 days after the last plasma exchange or anti-VEGF therapy. Its really place in the research world is to differentiate what is a continuation of a prior event from a new distinct event, which we would call a relapse. So event 30 days beyond the last plasma exchange or anti-VEGF therapy would be considered a relapse. But for patients, it's clinically very significant. At least a third of patients will suffer these, and they're most common in the first 2 weeks. It results in readmission to the hospital. The line is replaced, plasma exchange is restarted, and really they're starting over with their course of plasma exchange therapy. The present things that we do in terms of immune suppressive therapy are shown here, and this panel on the right is steroids and rituximab. And obviously steroids will suppress the anti-ADAMTS13 antibody production and lead to hopefully recovery of the ADAMTS13 functional protease. Rituximab, I know you're all well aware of. It's an anti-CD20 antibody that really does the same thing, but has a much durable effect after the treatment is stopped by clearing out B cells that are producing these anti-ADAMTS13 antibodies. In the panel on the right, you'll see some data from a different study that we did comparing cyclosporin and prednisone as adjuncts to plasma exchange, with the endpoint being exacerbations, and is there a lower exacerbation rate with better immune suppressive therapy? And the data really aren't important, but the summary is cyclosporin was not better than steroids at improving the ADAMTS13 and at decreasing the rate of these exacerbations. But there was really no significant difference between both groups. I think one important reason why is you can see the time to the improvement in the ADAMTS13 activity. So here's the inhibitor concentration above, but it's easier to focus on the ADAMTS13 activity pre-treatment, and then week 1 starts 1 week after hospital discharge, so after they're already out of the hospital. Could be 1 to 2 or even 3 weeks after their initial diagnosis. But you can see even at this point, week 1 and week 2, it takes really until the median ADAMTS13 activity starts to rise and start to significantly increase. Rituximab is a very good agent in the treatment of TTP. It helps to prevent or delay relapses of TTP. But in these data you can see from my friend Murray Scully, you can see the suppression of the inhibitor IgG concentration, as well as the improvement that you're looking for in the ADAMTS13 activity, doesn't start to get over this 20% threshold until day 22 to 29 after their admission to the hospital. And I should mention that this is with rituximab given in the first 3 days. So both steroids and rituximab beneficial in the treatment of immune-mediated TTP, suppressing the inhibitors and recovering ADAMTS13 protease activity, but it generally happens after 2 weeks, which is exactly why we see these exacerbations occur most commonly in the first 2 weeks. So talking about caplacizumab, which is something I'm sure you're all aware of, certainly a very interesting compound. Some controversy associated with it, I think justifiably because of the cost, but not the efficacy or the safety. And this was a small molecule, an antibody derived from llamas, so members of the Camelidae family that have these heavy chain only antibodies. And these can be derived into nanobodies and targeted at any particular target. And in this case, caplacizumab is an A1 domain blocking nanobody. So it binds to the A1 domain of VWF, preventing the formation of microthrombotic disease. So the caplacizumab does not alter the underlying disease, but rather blocks the formation of microthrombotic disease, blocks the downstream effects of not having the ADAM TS13 protease function. So if you will, buying you time until you can correct this ADAM TS13 deficiency. So the phase 2 study was a single-blind randomized study. Important to note that they got caplacizumab or placebo until remission, and then 30 days after discharge from the hospital, which covers this exacerbation time period, they continued medication or placebo. What I think was very interesting from the study, and this was published in the New England Journal, Flora Pavandi being the lead author, as you can see, certainly in the caplacizumab treated patients, I think you can see my pointer here, the median time to a normal platelet count is 3 days versus 4.9 days. So 3 versus 5 days certainly suggests you're blocking microthrombotic disease and allowing for recovery of the platelet count sooner. And that's an important endpoint. It helps you really shows you the efficacy of the drug. But I think what's more important is when you look at the exacerbations, 8% versus 28% of patients. So this drug really did a very good job of blocking exacerbations. What was initially found, and I think misinterpreted by some, was the relapse rate. And the idea was this drug is increasing the relapse rate. Well, the reality is likely not. 7 of these 8 recurrences happen in the first week of stopping the caplacizumab. And likely what happened was that the drug was stopped before the correction of the ADAM TS13 activity, which is really what you can see in these follow-up data that looked at these patients with exacerbations. So in the placebo arm, there was 9 exacerbations versus 3. And you can see these all occurred in the patients, nearly all occurred with undetectable ADAM TS13 activity. But in the caplacizumab arm, these 7 patients of the 8 that were called relapses really was a continuation of that previous episode. So it was the unmanaged or uncorrected ADAM TS13 deficiency when the protection of the caplacizumab was removed that was then permissive of relapses of TTP, if you will. So it was this phase 2 study that informed the Hercules study or the phase 3 study. And really the main difference in this study, everything else was the same. It was randomized, it was placebo controlled. After those initial data, the accrual went quite well and quite quickly. The main difference in this study was at the end of that 30-day time period, the physicians had the option to extend caplacizumab, extend the protection for an additional 28 days to allow time to intensify or add immune suppressive therapy. And that's certainly what you saw in that study. The data on this study saw the same thing that you saw in the Titan study. And I will focus on the exacerbations because I think that's the most important. You saw 38% risk of exacerbation or occurrence of exacerbations in the placebo arm versus 4% in caplacizumab. And during the follow-up, which is after that, you saw some patients, again, with that same phenomenon. But certainly, you're able to block these early recurrences, block these patients from having to go back to the hospital to restart plasma exchange therapy. The hypothesis has always been that this may also, because you're blocking the downstream effects of the disease, you should have an impact on mortality. Mortality still happens in TTP, probably 10 to 15% as an accurate estimate, but certainly the mortality rate is going to be lower in any patient enrolled in a study, as the very sickest ones likely would not be approached for enrollment. And if you look at the refractory TTP rates, and this is defined in this study as the absence of platelet count doubling after 4 days of treatment, was not significantly different, but certainly suggestive of more of an issue with placebo and prevented by caplacizumab. It's important to talk about safety and bleeding. And as you might expect in any medication that blocks or impairs VWF function, bleeding is the primary side effect that was seen in this study. And for the most part, it was mild bleeding, manageable bleeding. Epistaxis, gingival bleeding, some bruising, heavier menstrual cycles, all what you might expect. And essentially, as we like to tell our patients, we're kind of taking you from a thrombotic phenotype to a mild bleeding phenotype, which is not great, but it's certainly better than the thrombotic phenotype, and it's more manageable. And most of these side effects were relatively easily managed without the need to stop the medication. So where are we going in the future with TTP and its treatment? And do we get to a world where we're doing TTP treatment without plasma exchange? And I certainly think we will. The first report of doing this without plasma exchange, that is the treatment of TTP, I believe, is from Louisiana in the United States, and a Jehovah's Witness who by religious conviction will not take blood products, was treated successfully with caplacizumab without the need for plasma exchange therapy, just immune suppressive therapy, and recovered nicely. So it raises the question, is plasma exchange equal to caplacizumab? Are they both just temporizing measures? Is there a biologic effect of plasma exchange, or can it be replaced by something that's much easier to use and administer? And certainly I think the field is moving toward away from the need for plasma exchange. This is a very informative case that we published soon after the Louisiana case. A patient of mine who came into the outpatient clinic and said, I'm having abdominal pain, I'm having nausea. And those are fairly common symptoms. They're not in the pentat of TTP, but they're certainly a very common symptom that patients will tell you, and presumably from microthrombotic disease in the enteric system. But indeed, she had a platelet count that was about 70,000. Her LDH was elevated, and she said, do I absolutely have to come in the hospital for plasma exchange? I don't want the line. I don't want plasma exchange. And we discussed it, talked to our pharmacy, and were able to get her access to caplacizumab. So caplacizumab was started actually as an outpatient. She actually begged us to not start the steroids with the side effects. And with the impending use of rituximab coming up, we thought that wasn't unreasonable. Again, we're going to temporize her with the caplacizumab until we can target this ADAMTS13 deficiency. And as you can see, over the first 3 days where we had her come in every day to be checked, she had what you would expect, a rise in the platelet count, a decrease in the LDH, and eventually over time, after 4 weekly courses of rituximab, correction of the ADAMTS13 deficiency, then the ability to safely stop the caplacizumab. And she's doing quite well at this point, continuing in follow-up, but really driven by her and her wishes. You're seeing right about the same time we were doing this in the US, my colleagues in Germany were doing the same sort of thing. And from a retrospective study, they identified 6 patients where, for varying reasons, poor venous access, milder presentation, and a refusal for plasma exchange, if you will, they approached patients to treat them without plasma exchange and just caplacizumab alone with immune suppressive therapy. And these figures are a bit small, but use the pink demonstrates where the caplacizumab is being given. The blue, the bright blue, is the platelet count, and the green is the LDH. And I think what you can see quite consistently, and again with the ADAMTS13 in red, is that these 6 patients were actually successfully treated with just caplacizumab without plasma exchange. And the approach they took was to recheck the labs in the first 5 to 6 hours after initial presentation. So when they documented improvement in the LDH, stabilization of the platelet count, they safely moved forward with just the caplacizumab and not the plasma exchange. But again, additional evidence that this can be done safely, and really the data and evidence that led to the MyARI study, which is ongoing now, which is a study of acute TTP without necessarily the need of mandating plasma exchange therapy. It can be added at physician discretion. So I think that's very exciting. It's very interesting. What I think is more interesting and more a better way, more beneficial, or will be beneficial to patients, is trying to deal with these long-term complications. The old view is this TTP of an acute disease. I would tell you that this is a chronic disease, and the development of a diagnosis of TTP can lead to many long-term sequelae. I think this is very illustrative. Shreve is one of my fellows now, my God, 13 years ago, first did this study in a patient of ours who unfortunately died from an acute TTP episode. And it was remarkable that she didn't die from refractory TTP. She was responding to therapy. She actually died from refractory hyperkalemia. Her kidneys could not handle the load. And it's well known that patients, and these are data from Dr. George, and I'll show you more of these in a little bit, who actually is my mentor over the years. But back in 2013, they first discovered, and really going back even before then, that these patients are not necessarily going back to their baseline. Mood disorders, depression, PTSD are quite common. They have very clear neurocognitive impairments, more in short-term new memory type of areas. We think chronic kidney disease, chronic vascular disease involving strokes, and a higher all-cause mortality in these patients after an initial diagnosis of TTP. It does not, from multiple studies, seem to be related to the severity of a TTP episode, does not seem to be related to the number of TTP episodes. What you can see in our pathologist who looked at the post-mortem slides from our patient that said, and this is a 30-year-old woman, that said she had hypertrophied myocytes and she had sclerotic glomeruli and atrophic tubules that she said looks like these slides look like they're from a patient with 50 to 60 years of poorly controlled hypertension, more of a vasculopath, if you will. And these are the data I referred to earlier from Dr. George, looking at long-term follow-up and survival in patients with TTP. And they looked at 70 patients enrolled in the registry that were confirmed with severely deficient ADAMTS13 activity. So 57 survivors as of 2012 that were compared to US norms. There was a greater risk, as we already talked about, of mood disorders, depression, and hypertension. But what was most striking is the probability of death that you can see in the black line, and these are the confidence intervals, was greater in those that had a prior diagnosis of TTP than those that didn't. So just having a diagnosis of TTP increase your risk of dying during long-term follow-up. Now, you might just say this is all from TTP and relapse TTP, and for a couple of the cases, that certainly is the case. But if you look more carefully at the cause of death, and this is what led to additional work in the field, you're seeing cardiovascular complications at issue. You're seeing hypertension. You're seeing acute coronary insufficiency, cerebrovascular accidents, some malignancies, but more strokes, more cardiac events, in what is a relatively young population of patients. There's a couple older patients, but this raised the question of what is happening to these patients in long-term follow-up, and what are the rates of these complications and why are they occurring? And this led to some work from my fellow who's now at the Baylor University in Texas, Senthil Sukumar, who looked at a retrospective study of cardiovascular disease and mortality among TTP survivors in remission. So this is a retrospective study of both our registry going back to 2003 at Ohio State University, but also Shruti Chatterjee from Johns Hopkins, looking retrospectively in their database, which really started around 2014 and moving forward. And if you look at the patients in the cohort demographics, there were a total of 222 patients with acute immune-mediated TTP. 9 died during their first episode, so obviously could not be followed. There were 213 patients that survived their first episode that were available for a long-term follow-up. And about half of those that had remission ADAMTS13 available. And that's one of the strengths of having a registry. We've been able to bank samples now going back 20 years now in patients. And I've also been regularly measuring the ADAMTS13 activity, initially to look at their relapse risk, but now it's becoming more informative to help look at these long-term complications and why they're occurring. If we look at the mortality rate per 100,000 person years, and you can see, and this is the cohort from Ohio State and Johns Hopkins, a higher mortality rate in TTP survivors compared to the reference population. You see a more striking difference in males in the risk of dying, and the suggestion of the same in African Americans. But certainly raising the question and confirming Dr. George's data that there seems to be an increased rate of death in remission in follow-up of TTP. So again, why are these deaths occurring? And on the left, you can see both the causes of death in the US population in 2017, but also the causes of death in our cohort of patients. And cardiovascular, relapse TTP obviously was there 27% of the time, but cardiovascular disease, 28% of patients died of cardiovascular disease and complications. If you look at our data now compared to the Oklahoma registry, you see a sort of similar story. Maybe more relapses in our cohort. Maybe it's just closer follow-up on our registries today that allow us to better characterize them. But you are seeing cardiovascular events in both our cohort and the Oklahoma cohort, as well as other causes of death. Vascular primarily in origin, we believe. If you look at what were the risk factors in this retrospective study for dying in remission from TTP, and I would emphasize that all of these data I'm showing you are from patients in remission. Male sex certainly fell out. Increasing age increased the risk of dying. And there was this suggestion now that mortality, even though complications haven't been tied to it, that the number of TTP episodes might be a risk factor. We looked and correlated this with traditional cardiovascular risk factors in hypertension, chronic kidney disease, but either due to limited sample size or maybe they are not as important, they did not contribute to the mortality. In some previous work, also done by Sentil, you saw that some of these major adverse cardiac events seemed to be more common in females, and they were also occurring at a younger age in both males and females. So suggesting that the causes for these cardiovascular events might be different and subtly different than in other non-TTP surviving patients. I think some of that becomes increasingly clear as you see some other follow-up data. And these are data from the Johns Hopkins group and Dr. Uprady, led by Shruti Chaturvedi, and looking at the risk for strokes in patients who, again, have survived a previous TTP episode. And what they found was roughly a five-fold increased risk for the development of strokes in remission. What's also interesting is all of the strokes that occurred in the ATOM TS13 less than 70% cohort. So in follow-up, the patients who had less than normal ATOM TS13, those are who developed the strokes, suggesting that that may be a risk factor. And we'll talk more here in just a little bit. I believe that's certainly important, but it may not be everything. So we're starting to see now some quantification of this risk and starting to get some risk factors. And this led to some recent work by Shruti as well that she just presented at ASH this year, looking at silent cerebral infarction during TTP in remission. And what she did is look at 39 patients that were enrolled with immune-mediated TTP in remission, had an annual MRI, and in this report only had one MRI, but had also cognitive function testing done, which was the NIH toolbox that validated multiple cognitive domains, including executive function, sort of a functional test to see how their brains are functioning post-TTP. 32 patients had MRIs completed. You can see the median age, predominantly female over males. And what was quite striking, and in this study, silent cerebral infarcts were described as infarct-like lesions of at least 3 millimeters in size, but without any known or corresponding neurological deficits. So of these 53 patients with silent cerebral infarcts, only half of them had known prior stroke. If we look at their cognitive function and cognitive impairment, as a group, all of these patients had mild or moderate cognitive impairment of 23 or 31%, the rates. But if you look at the group that had these silent cerebral infarcts, you had greater rates of mild or moderate cognitive impairment, really suggesting that these are silent cerebral infarcts, but they do not appear to be benign. They certainly don't appear to be benign and are likely significant in patient functioning as well as potentially the mortality. And strokes were also associated with the development, the prior stroke with silent cerebral infarction. So we're starting to get to a point where we understand these patients, once they have a diagnosis of TTP, they do seem to have a lower mortality rate, a higher mortality rate. And efforts now have been sort of to look at their functioning prior to mortality. How are these patients functioning? How are they doing? And this is work done by myself and Murray Scully now about 10 to 12 years ago. And it was a fascinating test at the time. It was called a Cogstate test. And what this test was a laptop-based test which showed playing cards. So the test was meant to be intellect, language independent. So something that most people know and understand, playing cards, was used for this. And so there's 4 different tasks shown here to try to test their cognitive function, as well as the speed of processing and things like that, with each test looking at slightly different domains. So in this detection task, they just had to hit a bar, hit the space bar as the card turned over. So has the card turned over, yes or no? And then they were just asking a simple question, is the card red, yes or no? And then starting to test some of these short-term memories, which is where the deficits occur in patients with TTP. They were asked the question, does this face-up card exactly match the one that you just saw? Yes or no? And one card learning. They were asked the question, have you seen this card before in this task? Seemingly simple tasks, but I'll tell you, this is where some of the functional deficits lie in these patients. There are these new memories. And what you can see in red is the functioning of the TMA patients. Here's normal, and each Z figure relating to the magnitude of the deficit. So the larger the negative number, the greater the deficits. And as you can see, these are the 4 tasks, and you can compare it to patients with overt dementia, illegal blood alcohol content to drive a car in most states in the US, and mood disorders. And what you can clearly see is these patients functioned much worse than normal controls, and they were impaired. And you saw this more strikingly in the one card learning. Have you seen this before? Functioning even worse than patients who were legally intoxicated or patients with dementia. So this started to put into context, even before you get to mortality, functioning may not be normal in these patients. If we look at also headaches, and we started to notice in our cohort, patients were complaining of headaches in remission of TTP. And we found out and sort of researched this HIT6 headache survey, which was a very short survey that could be done in the outpatient clinic to help judge how headaches are functionally affecting patients with a prior history of TTP. The test and the study itself was shorter than the consenting process to enroll them. But we enrolled 31 patients with a prior history of TTP. Nearly all of the majority had TTP. They were at least 3 months since their last acute episode. And as you can see, the scoring system, 49 or less, has no impact. And as you get higher with the score, the headaches are having a greater impact on your life and your function, and getting up to 60, where headaches are severely impacting a patient's ability to function in everyday life. And you can see the mean score in patients with TTP really approaches 60, telling us that these headaches are really a functional problem with a prior history of TTP. So I think I've taken you through the initial treatment, some of the long-term complications, which I think are really the focus of care and research going forward, and it's really the focus of my energies now. But also now turning the tables and trying to understand why these things are occurring. And the ADAMTS gene activity I mentioned earlier is very important, and it's clearly going to play a role in many things, but it may not be uniform, as we'll talk about here, or may not be the only factor, as we'll talk about, I should say. These are work from my late collaborator, Haifeng Wu, back from 2008, and since going back to 2003, we've seen our patients every 3 months in the outpatient clinic. We thought it was a reasonable time frame to monitor them, to monitor the ADAMTS13 activity. So what we were able to do is then retrospectively go back and look at the risk of relapse in the 3 months following their most recent ADAMTS13 measurement. And if you look at all comers, you can see as the ADAMTS13 activity decreases, the probability of relapse in the next 3 months only starts to increase. But it's not so impressive getting up to 10% over the next 3 months. But if you look at the probability of relapse broken down by age, with the youngest age on these higher curves, you start to see putting together undetectable ADAMTS13 activity with younger age markedly starts to increase the risk of relapse that now approaches 45 or 50% in the following 3 months. So I think this is what first started to tell us that the ADAMTS13 activity in remission is important, but it's certainly not everything. And I think you saw the same thing. You saw the same thing in the mouse models, and the patients needed that second hit to occur. So certainly the correction of the ADAMTS13 activity is going to be important. And I think you can also see these in some data from the Rotterdam study from Dr. Sonneveld and colleagues. And they looked at the ADAM TS13 activity and VWF levels. And what they found is in the lowest quartile of the ADAM TS13 activity, which many of these patients would be in the normal range by our measurements in the US and most places around the world. It's the lower level, the lowest quartile of ADAM TS13 activity had a greater risk of dying and a greater risk of cardiovascular mortality. When you combine higher levels of VWF factor, so von Willebrand factor, antigen, and lower ADAM TS13 activity, you had an even greater increase at risk. And I should have said from the outset, this is from the Rotterdam study. These are patients over age 55. They don't have a diagnosis of TTP. Just looking at the role of the ADAM TS13 activity in the development of strokes and other medical complications going forward. So even the general population, this is starting to bear out as a risk factor, maybe not a major risk factor, but certainly one risk factor that may be important in stroke care going forward. The ADAM TS13 activity, I tell my colleagues, we have to remember that this is an in vitro approximation of what's happening in the patient's body. So we're trying to approximate it, obviously, in the lab. And what we found, we decided to look at our patients and correlate the ADAM TS13 activity with the presence or absence of these ultra-large VWF multimers. So how accurately does a low ADAM TS13 activity predict that ultra-large multimers are going to be present? And what we found was there was, as you might expect, a negative relationship between the ADAM TS13 activity and antibody levels. So higher antibody, lower activity, what you might expect. The log transformed ADAM TS13 activity and antigen had a positive relationship. So in general, as the antigen increased, the function, ADAM TS function increased as well. But we looked at in more detail the patients who did and didn't have ultra-large multimers present. And if you look at the median ADAM TS13 activity in those patients where we saw visually, and by Western blotting, ultra-large von Willebrand factor multimers are present, the mean ADAM TS13 activity was 15%. In those that didn't have them, the mean was 35.5%. What I think it's important to notice is that the range of the ADAM TS13 activity. So again, the ADAM TS13 activity is an in vitro approximation. There are some patients who still had ultra-large multimers despite what we would have called normal ADAM TS13 activity in the lab. But also patients who did not have ultra-large multimers present. They were not present, but still had undetectable activity. So when I asked the question, does the ADAM TS13 activity predict the multimer presence, my statistician gave me the answer, yes, but not absolutely, not if you're interested in precision. So it's a good test, but not a perfect test. The ultra-large multimers are obviously a much more difficult test to do. The other thing we found was some racial differences in the processing, with African Americans or Black Americans would be less likely to have ultra-large von Willebrand factor multimers compared to Caucasians, with all other factors being equal. So there's going to be other factors as well that affect the ADAM TS13 function. One other possibility we've looked at that we're continuing to study is the role of complement activation in immune-mediated TTP. And certainly complement activation is more thought of with atypical HUS or complement-mediated TMAs. Really, the first work was done many years ago in 2012 by Dr. Reddy et al. In Hungary, looking at patients with acute TTP and patients with serial samples. And what they found was complement activation as defined by increased levels of these split products. And what we typically look at are C5a and C5b9, which are looking at terminal complement activation. You can see BB, which is more focused on the alternative pathway, and C4d and C3a, giving you a sort of a picture, not a perfect picture, but a picture of classical or lectin pathway complement activation. And what Dr. Reddy found was that the C3a and C5b9 levels were higher in TTP patients compared to control. And as they were treated and got plasma exchange, these levels decreased. So we decided to look now several years ago, and these are from Trudy Wu, the daughter of my late collaborator, who looked at complement activation in pre-treatment samples, which is important because plasma exchange is obviously going to affect these levels. But looking at differences in the patients that died and survived. And as you can see, the patients were fairly well matched in most features, except for the serum creatinine. But in the patients that died, they had greater degrees of complement activation as measured by C5b9 and C5a, as well as BB. So looking at the alternative as well as terminal complement pathway activation. So it's hard to say, were these just sicker patients that had greater degrees of complement activation, or was it complement activation from something, antibody antigen interactions, other clinical issues that led to greater degree of complement activation and a greater risk of death? It's very difficult to say, but it's certainly something to think about. We took this a step further after seeing some lab work by Joel Moak's lab in Houston. And what they were able to show in the lab was the alternative pathway can be assembled and activated on ultra-large VWF multimers more likely than physiologic size multimers, suggesting a potential mechanism is linking these two different TMAs. And indeed, physiologic VWF multimers serve as a cofactor in the factor I-mediated cleavage of C3b to inactive C3b. So with factor I, it's these physiologic VWF multimers that help the activity of one of the controllers of complement activation, factor I. And indeed, large, ultra-large VWF multimers don't have the same cofactor activity. So you can see a world where ultra-large VWF can serve as a scaffolding for the activation of the alternative pathway, and as well lose some of the control benefits that it has in patients that physiologic size multimers have. So to take that a step further, we looked at some of our bank samples, and using a lasso logistic regression modeling, we correlated these complement biomarkers as well as other clinical factors with the presence or lack of presence of ultra-large VWF multimers. So a negative number demonstrates an inverse relationship to the presence of ultra-large VWF multimers. A positive number demonstrates a direct relationship. And what you can see we found here with these markers of complement activation. So again, terminal complement, as well as the classical with C3A, C5A and C3A were positively associated with the presence of ultra-large VWF multimers, suggesting that there may indeed be complement activation occurring in patients with immune-mediated TTP, mediated by these ultra-large multimers that are permissive of complement activation and less able to control it, like physiologic multimers may be able to. That's certainly just a small fraction of where the field's going. There's a lot of interesting people doing a lot of interesting work, and these are slides here demonstrating and showing a lot of the people I've worked with over the last 20 years who've been immensely helpful from the world of TTP, and the late Evan Sadler to my Kohler's a complement expert, and some of my TTP mentors, Bernhard Lemley, Dr. George, and some colleagues of mine as well. So with that, I'll stop and answer any questions that you have, and thank you for your attention today.
Thank you, Dr. Catalan. That was a wonderful talk, and you presented so much of your research work, especially the long-term follow-up and the studies. They were very intriguing. So our colleagues are here. They may like to ask you some questions. We start with Dr. Samir.
I thank you, sir, for a very enlightening lecture. My question refers to that category of patients which you mentioned where they have a congenital defect and it's only a second hit that actually causes the TTP to be manifested. So in this category, is it always an immune phenomenon that sort of develops in these patients and you have an immune-mediated TTP, or is it that there's it's not actually immune, and for some reason the congenital, the deficient, there is a congenital sort of underproduction of the ADAMTS 13. So what happens in these patients? What happens to them subsequently? How do you treat these?
Yeah, it's a good question. I think in the cases you're referring to, I think these are congenital patients who were just born without protease function, but yet either the levels weren't low enough in some cases, or they never got that second hit. most of them are, yeah, and pregnancy serves as that second hit. There's a nice family I take care of where they were all discovered to have congenital TTP by a very astute physician in Cincinnati, Ohio, 20 to 30 years ago, all three siblings. And all three have levels about the same, 2 to 3%, but none of them get into trouble unless they have a severe event. So an immunologic event, so a viral infection, a medication has done it to some of the patients. But the youngest one I take care of now, I worry about her with her undetectable activity, and I worry what 50 years looks like. But for a 21-year-old female who's asymptomatic, and her chemistry, her LDH, her platelet counts are normal, she wants no part of plasma infusion therapy. Now, maybe that changes with recombinant, but I think it begs a question of are these patients at risk for complications like the immune-mediated TTP patients? And I think they are. They're not all at that same risk. So understanding the degree of risk, I think, is going to help us know how to treat these patients in the future.
Yeah. Thank you.
Thank you, Dr. Vidisha.
Thank you for that wonderful talk, sir. So my question was on the follow-up of these patients. So you mentioned that they are more prone to silent infarcts, headaches, and neurological complications. So do we have some recommendation or guidelines how to follow up on these patients?
It's a real good question. We've just finished looking at, in our USTMA consortium, about 30 patients every 3 months, sort of a standard look at these patients every 3 months with blood samples to study some biomarkers and to measure their function. And we hope to report that at ASH this year. And one of the reasons we want to do that is to really give some data and a framework to know how you should be following these patients. I think we're at the stage now where we all agree bad things are happening to these patients in remission. How do we screen for them? I think is still needs to be discovered and determined. I think we might be looking at serial every 1 or 2, 3 years, maybe MRIs of the brain. Some of these functional batteries are going to be important. And what is very interesting and a bit frightening is, I can't talk too much about it yet, but we're doing actually a follow-up study of patients. We follow a cohort of about 100 every 3 months, and they're very active enrolling in clinical trials. And we're now looking at, from a cardiology colleague, looking at cardiac MRs in these patients. And these are younger patients, 30 to 50 years of age. And I think you might see a TIA, you might see a stroke, because you've got very little redundancy in the brain. But in the heart, we're seeing patients now in follow-up who may have hypertension, who may not, who seemingly are fine, but yet are showing signs of small vessel ischemia, very much like a sickle cell patient or a diabetic with long-term complications. So our cardiac MR is part of the future. The harder question is, what do we do to prevent these things? But I really think that's where the field's going, and that's where it's more important in the future for these patients. Sorry, that was a long answer.
No problem, sir. And the role of ADAMS13 in screening out cardiovascular risks in patients, sir. Yeah. Where do you think that is going?
We've looked at it with Shruti Chaturvedi and Senthil Sukumar's work, and it's suggestive, but it's not perfect. And one idea has been the studies are just not large enough. I think what we're going to find out is ADAM-TS13 is actually very important, but it's not the only thing that's important. And I base that on really following some patients for 20 years. And I would tell you, I've seen, unfortunately, a few patients who develop multiple cognitive mood disorders and cardiovascular complications and die. And some of them have not had. One of my worst patients in terms of long-term complications had one episode of TTP 16 years ago, and with prophylactic therapy now on nothing, has normal ADAM-TS13 activity. But she looks worse than many of my multiple relapsing patients. So I think we need to look at more of what might be contributing to this.
Thank you. Dr.
Thank you, sir.
Thank you, Professor, for a wonderful lecture. This regarding the pregnancy, patient has got a TTP and one episode, and during the pregnancy, how should we manage these patients? Are any stress situation during surgery or infection? And how should we manage these patients?
Yeah, excellent question. I'm dealing with it right now with a pregnant woman who was just diagnosed with immune-mediated TTP. And I think over the years, our experience has told us, and there's more data, but not a ton of data, that tell us if you are undetectable your ADAM-TS routine activity, whether you know about it or not, your risk of relapse during a pregnancy is exceedingly high. So our patients who want to get pregnant, we monitor their activity. We may do preemptive rituximab before they get pregnant. We've used cyclosporin during pregnancy as well as rituximab, but obviously many times pregnancies aren't planned. So when we find someone with a history of TTP and they are pregnant, we will monitor their ADAM-TS routine activity every 2 to 3 months during the pregnancy. And in patients in remission who aren't pregnant, it's a risk benefit ratio discussion about preemptive therapy. In pregnancy, we really push them to be treated with cyclosporin or rituximab because we view it as really a relapse waiting to happen in pregnancy.
Any role of antiplatelet or the anticoagulation in these patients during pregnancy?
Yeah, it's a good question. It's certainly not in terms of, I mean, the real question I think is in pregnancy, but also all patients. And I get asked that a lot. Should all of these patients be on a baby aspirin, you know? And not to prevent TTP, which has been studied already and not effective, but to prevent these long-term complications. And I think the answer is, I don't know. But if I had TTP 15 years ago and saw these data, I would probably be taking a baby aspirin every day. So I think we're getting pretty close to telling our patients, based on the stroke data and the cardiovascular data, you should be taking a baby aspirin. But is there something else we need to do in addition to blood pressure control? I think we need to learn that.
Thank you, sir.
Thank you. Girish?
Hello. Yeah. Thank you, Dr. Kaufman. This is really nice talk, and it's about a lot of data about the long-term complications. Some of the practical questions in India, basically one is, when do you call it's a refractory in acute setting? Like after how many plasma exchanges you call it as a refractory? And because of the non-availability of the capsizumab, whether we can have alternatives like a cyclophosphamide intravenous or anything like that.
Yeah. I think the best thing I've ever heard to describe this is refractory TTP is very difficult to define clinically and for research, but we all know it when we see it. And it's bad. It's usually an LDH that's rising, a platelet count that's not improving. And if you look at cardiac troponin levels, you'll see rises in the troponin, which is very ominous.
Right.
Caplacizumab does do a very good job, I believe, of preventing a lot of this, but it's not available everywhere. And in situations where we don't have access to it, I think you mentioned cyclophosphamide. You know, we know rituximab is going to help, but it's going to take 2 or 3 weeks. And we know the prednisone should help, but it's going to take 2 or 3 weeks. We do exactly what you said before, or when Capla is not available. We will use intravenous cyclophosphamide in an effort to shut down the process. Variably effective, I would tell you. It's hard to know for sure.
Sure. Sure. I mean, this is one thing. I mean, I don't know how the situation is, but this plasma exchange, in many centers in India, they use the hemodialysis machine to do the plasma exchange. But I've seen a lot of blood pressure variation and practical difficulties during that time. And is there any data about like should be done by the apheresis, or is that the kind of like a better option than the hemodialysis machine?
You know, I'm not a blood banker. I can't give you a great answer. I think in general, the larger the volume that you can do, the better. But there's a limit to it, I think, as well.
Yeah.
I think there's going to be a lot of debate. I think we're going to see data that caplacizumab alone is as good or better than plasma exchange without the deep line. But I think you're going to see some pushback from people who do a lot of plasma exchange for a living. And it's going to ask the question, does plasma exchange really by itself have a biologic effect, or is it just a temporizing measure? I think it's the latter. I think it's more temporizing.
Right.
But people who do that for a living have a different viewpoint, I think.
Temporary.
People who know more about it than I do.
Sure. Thank you.
Anyone else has any question? Okay, there's a question in the chat box. Can ADAM-TS activity guided use of Kapla truncate the duration of its use and make it a more cost-effective strategy?
That's an excellent question. I think that's exactly where the world's going to, is trying to use that. You know, in the regulatory approval in the US, it's based on the phase 3 study. But we've had patients, one on the Hercules study, who had a bleeding complication, and she was 2.5 weeks into her capla dosing of refractory epistaxis, and we gave her Humate-P to reverse the effect of the caplacizumab. And I knew just from 2 days earlier she had normal ADAM-TS13 activity, so I was able to stop the caplacizumab safely. And some of those data I showed you from the Germans, the German group have really done a good job of sort of pioneering the stopping it early. So it's not just 30 days, you're exactly right. Once you've recovered function, you can safely stop it. I think the problem with it is not as much the number of doses, though. It's just, it's so expensive. It was priced ridiculously, leading to the cost-effective issue.
The next question is, what's your views are on the preemptive rituximab during follow-up of these patients?
Excellent question. I think it's really the uniform. It's the standard of care in the US and many countries in Europe now. We sit down and talk to patients, and I show them those data about the relapse risk, you know, approaching 40 to 50% in the younger patients, lower in the older patients. But when I talk to patients about a risk-benefit analysis of the risk of rituximab versus the risk of a relapse of TTP, to a man, every patient wants nothing to do with the relapse of TTP, and they're more than willing, if they have access to rituximab, to do it. Someone who clearly has undetectable activity and already demonstrated a relapsing phenotype, multiple relapses, there's no question they need it. But I think it's fairly uniform in the States, and in my practice, we do it routinely. That lady I showed you who got the capula alone is actually coming in now. It's 3 years later. She's coming in next week for a course of rituximab again.
So can I extend this question? You give rituximab to those patients where there is at least a lab evidence that a process is on, either by platelets dropping or LDH going up or some hemolysis, or, I mean, how do you decide which patient, when, frequency?
Yeah. You know, it's the patients that have a normal platelet count in remission that we're going to give that rituximab to prevent relapses. I think the question I think you're asking is the acute episode. When they show up with acute TTP, do they all get rituximab? And I've been back and forth on that. I think with more use of caplacizumab, we know the sooner you give the rituximab, the sooner you're going to get improvement in the ADAM-TS13 activity, and the sooner you're going to be able to stop that expensive drug, has driven me to do it more and more. So we do give rituximab early on, but I really tell patients the benefit of rituximab is going to be 3 months from now. It's not going to be, it's really preventing relapses where it's beneficial. It's not going to prevent these exacerbations. And although it's expensive, caplacizumab is very effective at preventing these early relapses, exacerbations.
Thank you. So one question about TTP secondary to SLE. Is the treatment different?
No, treatment is not different other than doing your best to control the lupus if you can. The SLE obviously is going to lead to, when you have one autoimmune disease, that we believe you're at greater risk of getting another autoimmune disease. So I think they run hand in hand like that. And there are certainly patients who with lupus who develop TTP, but I think almost more commonly we see TTP and then the development of lupus months or years later. So the treatment's the same, but anything you can do to control the lupus, I think, is going to help prevent relapses.
Dr. Chandrakala, you have a question.
Yeah. This is regarding the Humate-P you mentioned. Congenital TTP, can we use this drug? And how frequently we should use this Humate-P, which has intermediate purity factor 8 along with BWF?
Yeah, I should have been working. So we use that as an antidote to the caplacizumab for bleeding. So she clearly had bleeding. She had a dose that morning. And by giving the Humate-P, we were able to get rid of the effect of the caplacizumab. So it was on the study. It was hypothesized to be effective. We didn't know it had never been given. It actually was really effective in stopping the bleeding on the caplacizumab. It also raises the question, if we start doing caplacizumab alone and then somebody needs plasma exchange due to deterioration, or they develop a bleed. You have to put a line in something. What can you do? And it looks like you can reverse the effect of caplacizumab with HUMAP. Do you need to do that before an invasive procedure? We don't know, probably, but I don't know. Does somebody need a lumbar puncture after they've been successfully treated for TTP and they've got caplacizumab? It's an excellent question.
Thank you.
The other question is the plasmic score validated in pediatric population?
I don't believe it's been validated in pediatric populations. And although we don't look at kids as just young adults and vice versa, I do think the same principles are there, meaning a lower platelet count and a lesser degree of renal injury. So a lot of times I'll tell my colleagues at Children's, that the basis of that plasmic score is the platelet count, the creatinine. And if you have an unexplained TMA clinical picture with a platelet count that's typically less than 10,000, and especially 30,000, and you don't have renal failure, I'd be very worried about TTP and start empiric plasma exchange therapy until you get the test results back.
Next one is a case scenario. During the treatment with plasma exchange, the platelet count has come up to more than 100,000, but the cystocytes are 12 per 1,000. Is it safe to stop the plasma exchange?
It's a good question. It's my colleague, one of my teachers here at Ohio State, Eric Kraut, still talks about the reticulocyte count and the schistocytes, and I think those were accurate ways in the past of looking at it. I don't know if they are accurate anymore. I think the platelet count being normalized, the LDH being normalized, tells you the disease process is shut down. Those microthrombi that were formed, I think, are still going to be there. So I think you're still going to have schistocytes. So I worry more about the recovery of the ATOM TS13 and the platelet count and the LDH more so than I worry about reticulocytes and fragmented cells in the peripheral blood.
Thank you. The other question is about the frequency of giving rituximab in a patient who has relapsing courses.
Yeah, it depends. I think what you see in the IHTH guidelines is the use of rituximab should be guided by the regular measurement of the ATOM TS13 activity. So it's quite interesting, the variability. And there's some interesting work from Marie Scully looking at, looks like in her cohort that there was a delay in the recovery of the ATOM TS after caplacizumab. But I've also noticed that the recovery of ATOM TS13 activity in patients in remission can vary. Some patients will go 3, 4, 5 years. Some will have a year to year and a half. We think there's a racial component in that Blacks in the US seem to respond less well to rituximab. I think when the world kind of changes in the next year, 2 or 3, that we're using less plasma exchange and more recombinant ATOM TS13 or caplacizumab, what that's going to be able to let us do is to better study these immune suppressive regimens that we think you can use a lower dose of rituximab, but there's so much variability in other confounding variables. Once it's just a capla or recombinant ATOM TS treating these patients, I think we'll get better data on, which immune suppression, how frequently, what's the dose.
The other part of the question is there a resistance to repeated use of rituximab? Do you lose out the efficacy after multiple uses?
That's an excellent question. We've just looked at this in our consortium, and you would think no, but it looks like there may be in some of the early, I don't think it's been published yet, but in Blacks especially, they seem not to benefit from rituximab the same, and the benefit seems to be more shorter-lived, meaning over time they need to be retreated sooner rather than later. Whether that holds up, I don't know, but that's an excellent question.
Thank you. The other question is, patients with transient platelet response to plasma exchange and who remain refractory to steroids and rituximab and other medications, what is your opinion about regular prophylactic plasma exchange every month or every 3 months indefinitely?
It's a good question. I mean, for certainly congenital TTP, we do that, right? We give plasma infusions regularly. It's sort of, you can take that same question and ask it in the pregnant patient. So the pregnant patient I have in the hospital now, I was asked the question, can we just do plasma exchange for the rest of the pregnancy? And my answer was you could, but you'd be having to do it at least every other day. And I think the problem with plasma exchange, while it can help by removing inhibitors, how often do you have to do it? I don't think once a month plasma exchange is doing anything other than making us feel better. You might have to do it every other day. And by the time you do that, other immune suppressives or even something like caplacizumab given long term might be more beneficial. I mean, if you have a longer half-life product, maybe something like that can be given instead of immune suppressive therapy to block the disease.
The other question is about efficacy of bortezomib.
Bortezomib is a very interesting drug, and there's been a lot of work in plasma-based therapies, sort of trying to get at, if you will, more proximal to the inhibition of these antibody formation. And there's some data in more refractory patients. I think it's interesting. I've never had the chance to use it. For some reason, I'm allowed to use many expensive medications, but bortezomib is more restricted. I've not been able to do it, even though I wanted to. Again, like I said earlier, I think the ability to do almost treatment as an outpatient with caplacizumab or recombinant ADAM-TS13 without plasma exchange is going to allow us to do multiple studies on what is the better immune suppressive therapy. And it sounds like blasphemy a bit, but you saw the data from the steroids. The steroids don't seem to improve the activity any quicker than the rituximab patients of Marie Scully's. So I even wonder if steroids are doing anything. And that's in part why we tried to look at cyclosporin. But I think using bortezomib up front might make some sense earlier on in the course rather than waiting for them to become refractory and have more and more antibodies.
Another question is, it has been reported by some groups that recognition of the open-closed conformation of ADAM-TS provides clinicians treating the patients of TTP with further biomarker to monitor and identify subclinical disease. Your thoughts?
Yeah, that's an interesting question. That's a lot of work. And we've done this work, some of this work with Karen van Houdelbeek from Belgium. She's very sharp and really has reported, like the question states, antibodies that actually multifactorial antibodies that may block function of the ADAM-TS13 protease, but may also change the conformation. And I believe it's this open conformation that predicts a greater risk of relapse. And we looked at this in some of our banked samples with her and did not get a clear answer. It's being studied as one risk factor. And I think it goes to what I mentioned earlier about the not necessarily consistent low activity multimers present. It may not just be in vitro activity that's important. It may be the activity in the context of the conformation, with the open conformation being more damaging and more predictive of relapse. So I think we're going to learn a lot more in the coming years. It's not just the number of the activity, it's going to be the function and the conformation of it. Not just the antibody, but the type of the antibody and what it's doing.
Thank you. Those were the questions in the chat box. Any question from the faculty here?
Very good questions.
Okay, then that brings us to the end of the question and answer session. Well, Professor, thank you very much, Dr. Catalan, for being with us and answering all the questions, giving the lovely talk and presenting your research data. It was a great learning exercise to all of us. We have participation from 27 countries today in the form of delegates.
Very good. Well, thank you very much for the invitation to present at the webinar. You inspired.
Thank you. Bye-bye. Have a wonderful day.
Thank you, everybody.
Intas is here to say the vote of thanks. Are you there? No. That's it, sir. Then thank you. Bye-bye.
Thank you, sir.
Thank you, everybody.